GAT ends up with a pressure of a minimum of 8, it should not cause hypotony because there is no external filtration. It equalizes the pressure to the episclerovenous pressure. So I was surprised postoperatively to find that the pressure was 2 to 4, which meant that something is fishy in there. I did gonioscopy, and all I could see was the patchy PAS from the previous procedures and the slit that refers to the part that was incised with the GAT. I kept her on topical cycloplegics and added steroids. The hypotony was still there. By the second month, she had developed maculopathy. I injected her with Saltinen, triamcinolone, again with no improvement. At some point, 3 months later, I thought, okay, that's it. I'll have to check. There's something wrong in there. Maybe there's a cleft there that I did not spot on gonioscopy. And UBM actually revealed an infranasal small cleft. So I went in a sort of exploratory plus minus interventional procedure. So this is the inferior quadrants. And again, you can see the slit here, a lot of patchy PAS, nothing that shows any passage or a cleft. And so I thought this is the part that was where the cleft was detected by UBM. So I did some dissection, and there you go. The cleft was very well seen after dissecting the peripheral antihysternic. It was hidden behind the attachments of the peripheral iris, and the only way to see it was to dissect these, to do goniosynochialysis intraoperatively. So clefts are a separation of the longitudinal fibers of ciliary muscle from the scleral spur, resulting in a direct connection to the suprachoroidal space and the subsequent hypotony. Topical medications are the mainstay of treatment, cycloplegics, to relax the ciliary body band and approximate the edges of the cleft, hopefully closing it. Topical steroids are controversial because they can delay healing, but at the same time, if the patient has hypertensive steroid response, it may cause some ocular hypertension to help out. Other modalities include laser therapy. You can apply argon laser to undergonioscopic view to the lips of the cleft, diode laser, endolaser, and cryotherapy for smaller clefts. For bigger clefts, they may need suturing. And there have been other reports, small case reports of different techniques, including gas injection to the AC with cryotherapy, scleral buckling, and the use of the haptic of a 3-piece haptic of an IOL in the sulcus or a CTR in the sulcus to approximate the edges, again, hopefully inducing closure. The best time to intervene is the first 3 months, although there have been reports of patients resolving after that. So for this patient having a small cleft, I decided to go for cryotherapy. I did 2 rows opposite to the site of the cleft, waiting 30 seconds with the cryoprobe. Half of the patients are reported to develop an IP spike after cryotherapy, mostly because of the edema of the edges. And this is exactly what happened to this patient. On the first week postoperatively, her pressure jumped up to 28. But unfortunately, and I presented her as a successful case the week after, and then when she came back, her pressure went down again. And at some point, a month later, I had to go in and revise her. Unfortunately, I don't have the video. So the take-home message here is that clefts can hide. The fact that we can't see them by gonioscopy does not mean that they do not exist. UBM and intraoperative exploration can help find them. And the other take-home message is, why did this happen, I wonder? So there are one of 2 reasons. Either an old cleft from the previous operations is reopened after the injection of Helon and so on, or the forcible injection of hydration fluid in the end, if it's close to the angle, can induce a cleft in itself. Thank you very much for your attention.
Thank you, Dr. Yasmine, for the very interesting case. And it's very interesting to have a hidden cleft that causes all the problem. So next talk will be by Dr. Usama Hakim from UAE. We have Dr. Smita.